Welcome to the Heart Factory. Now, what signs you want to look for, sir, when someone calls you and says, Dr. Hari, a patient is admitted under your care, what are the signs you want to see or look for?
It's a overall general outlook of the patient. That is the most important factor. If the patient is still feeling exhausted, that means his oxygen demand is not met. Either we are not able to adequately correct his hypoxia. So patients should not feel exhausted. Usually when hypoxic patients, when we arrive in AE, they will be breathless and they will be exhausted.
Hypoxia means how much do you expect saturation wise?
We can't term as a single value, sir. The problem is
what value makes you feel the alarm bells?
When patient is not feeling okay, that is the value. Really? So for elderly patient who normally has a 92 saturation, for them even they will be okay with even for 85, 80 they will be okay. But if their work of breathing is increased, if they are developing lactic acidosis, then we should intervene. Like for young people who has 100% saturation normal, they will be like roaming around with saturation 90, 92. They will not feel anything, and they will exert themselves to the extreme that they will have saturation 70, and then only they will come to ICU. That is one of the reason young people has to be very careful. They have to monitor the oxygen saturation. The best way is to challenge us. Like if you are on a call, like if you are positive, COVID positive, if you are having a cough, you can check your saturation before and after a challenge. Like you can walk for 5 minutes, 6 minutes. Then you can see if it is dropping 3 to 5 degrees, 5% lesser, then it signifies that your oxygen reserve is less. Like if you are on a call, you can take a 15 minutes talk to some friend, then you check and you see that there is 3 to 5% decrease in saturation. That means your oxygen reserve is low. Anytime you can become breathless, and anytime your saturation can drop dangerous level. That's the challenge.
So have a shower, come and see.
Yes, sir.
Have some supper, eat something for 10 minutes, see. So you should see before you do that activity, check the saturation, and from that, if there is 5% change, that means it is an alarm. You should be careful.
So it can become if somebody is 99 and after some exertion, after going to toilet, it is coming to 92, 95. Then after rest, it comes back to 99. That is the first stage. They are entering the first stage. It signifies that they may go permanently. Their saturation may become 92 or 89 like that. So it is the challenge which will bring out the what we do treadmill test like that. It will bring out the inadequacy of supply.
So you will first see anything else you want to say, like temperature, will it give an alarm?
Yeah, temperature not settling in 1 or 2 days is also alarming, and myalgia which is not responding to routine care is also alarming. Whenever these things happens, that means the inflammatory system is extremely stimulated and it is trying to fight with the virus. When temperature is not settling after 3 to 4 days and myalgia is not settling after 2 to 4 days, that means that. And one more important thing is recurrence of fever. The fever, usually people when patient develop, first time they develop fever, it will be very simple. They will take some analgesic and antipyretics, it will stop. 5 to 6 days after that or second week, if somebody is developing fever again, high grade fever, that signifies that the inflammatory system is active that time. Usually patient will have cough, fever, myalgia after 5 to 7 days. That signifies the viral phase of the disease is over and inflammatory phase is starting. When they have fever on the second week, that signifies the inflammation is happening in a large
second week. Fever in second week signifies greater inflammation in the body.
They will be normal in the first week, then suddenly they will develop fever again, inflammation again. That signifies that they are going in for hypoxia. They might develop hypoxia.
So you would be careful at that stage. Okay, sir. Now, on what measures you base your treatment, sir? Now, patient is come to you, people say, okay, the AE says, sir, a case is admitted to you. How will you start your treatment?
First, I look for their comorbidities. The problem is comorbidities will decide their ultimate outcome. If they have any comorbidity, that has to be addressed properly and it has to be controlled, like diabetes, hypertension, chronic kidney disease. That has to be addressed first. Then if they are in the viral phase of the illness, like first week, then we can start an antiviral. So the day of illness is very important. So what day of illness they are presenting to us. And the third thing is severity, how severe their hypoxia is. If they are mild, if they are enough with, if they are okay with the mask, like 5 liter, 10 liter oxygen, and their respiratory effort is not too much, then we can continue them in that angle. Even with if somebody is maintaining 96, 97 saturation with 10 to 15 liter of oxygen, but their work of breathing is high, that means they will definitely deteriorate. So we need to go little higher grade of management, like high flow nasal cannula or NIV, non-invasive ventilation. So we have to increase the FiO2 to make them comfortable first. Then first we have to stabilize the patient. Once they come, we have to stabilize them for 24 to 48 hours. We have to keep them in that stabilized state. Then only we can expect some improvement. If you are chasing behind the hypoxia, if you are allowing hypoxia to run before you, we will never catch it.
So what you meant to say, if he comes in the first week only, you give antiviral.
Antiviral. Second week antiviral is not going to be useful.
No use.
Either plasma or antiviral has to be given during the viral phase.
First phase only.
First phase
so
only.
5 to 7, before 7 days.
When they come in the inflammatory phase, inflammation has started, then there is no role for antiviral. May not be useful.
That is yet to...
After in the second week. Second or third week. Yes, sir.
So no use for Remdesivir.
Number one drug is oxygen. Oxygen is the number one drug. Next we can give now steroids. With the steroids we are getting good results. And next important drug is heparin. Only three drugs. And most important thing is we have to decrease the demand for oxygen. We should keep them in complete bed rest. Even for urination and defecation, they should not have any trouble. Passing motion or urine should not demand more oxygen.
So if he can do it in the bed, it's better. Because you want to reduce the demand for oxygen. Excellent, sir. Excellent. Sir, so Remdesivir, as you said, when to use? What if it is not used?
Yes, sir. Remdesivir is not a life-saving drug, and it is proven to reduce the short duration of hospitalization in patients with mild to moderate infection, and it has not shown to reduce mortality. So if it is available, it is good. Use in the first week. If it is not available, don't bother about that, because it is not going to prevent mortality. So go for oxygen, steroids and heparin.
If you use Remdesivir, how long you should give it?
The recommended duration is 5 days, and company says up to 10 days we can use, but most commonly we stop with 5 days. 5 days.
So it's not a must, but if you have it, use it in the first week.
Yes,
it's
sir.
of no use in the second week.
Or third. Yes, sir.
So what Dr. Ari says is oxygen is the first life-saving thing. Steroids, according to his experience, have saved a lot of lives. And the third would be heparin or any low molecular weight also is okay.
Yes, sir. It's
to
also
prevent
okay.
clots, I guess.
Yes, sir.
Okay, sir. Fantastic. Now, steroids, there are so many types. There's a bit of confusion. Which type, how long, oral or IV, and what side effects do you keep in mind while prescribing steroids, sir?
Yes, sir. Steroids, as you said, commonly used steroids in hospital setting is dexamethasone or methylprednisolone. Dexamethasone has advantage of dexamethasone is it is proven in this recovery trial. So it is the drug which is used in the study, and it doesn't have mineralocorticoid activity. It has only glucocorticoid activity. That is what we want for this. And the dose recommended in recovery trial is 6 to 8 milligram per OD dose. It can be given as IV or it can be given as oral also. So bioavailability is 80% for Dexa, so oral is also equally okay. Methylprednisolone, it is recommended in 1 to 2 milligram per kg dosage in 2 divided doses, because since it is not a long acting drug. So what we use is 60 milligram BD dosage for 5 days. Then we taper, and since when we start methylprednisolone, we need to taper and stop since it is short acting. For dexamethasone, it can be used from 5 to 10 days. After 10 days, it doesn't have any, it's not going to add any further good to the patient. And complication with steroids, all diabetic patients will have severe hyperglycemia. Their glucose has to be monitored, and it should be controlled with insulin, either short acting insulin given as an infusion or a long acting and plus short acting intermittent dosing. and we may need to use added oral hypoglycemic agents also. And diabetic patients commonly present with acute renal failure also, acute kidney injury because of viral infection, because of dehydration. Those conditions sometimes can be escalated by steroids. So that has to be monitored, and their kidney function has to be monitored. And drugs, remdesivir, they may affect liver function also. We have to monitor those aspects also. And cardiac patients, if some patients is having poor cardiac reserve, the mineralocorticoid activity in the methylprednisolone can put on lot of water in the system circulation, so they might have a overload condition that has to be monitored. And fluid balance, it's a very walking on a tightrope kind of situation. We can't allow hypovolemia also, because patient already oxygen is not delivered properly, and if patient develops hypovolemia, it is furthermore going to aggravate the condition. It is not like treating a pulmonary edema, put the patient dry. Here the dictum is euvolemia. Maintain normal volume for the patient. Don't overload the patient. Don't decrease the. That's what I feel, that is the thing will work. It's not hypovolemia.
Oh, any contraindication for steroids, in your time during this 2 years?
Patients with known gastric ulcer bleed. They may develop bleeding after 1 or 2 doses of steroids. That is the one contraindication which we are seeing. And some patients with active infections like tuberculosis, those patients will not be able to use steroids. These are the 2 conditions we are commonly seeing for.
But otherwise, you would just go ahead with
steroid, yes, sir.
Biggest life saving.
Yes, sir.
Super, sir. So I get your point. Now, oxygen, we have talked about it, but how to monitor? How frequently do you see? And we have talked about activity. How frequently you should one patient who is admitted see, or someone in that house should see?
So if somebody is in house, they can just do the challenge thing. Like they need not exclusively do exertion for this, but for their normal exertion they can check. That's enough for patients who are at home. Who are admitted in hospital, we monitor 3 times a day. But when somebody is hypoxic and admitted in the ICU, oxygen pulse oximeter monitoring will be done daily. It's a continuous process. Patient has to wear it, and we will continuously monitor that. And ABG, arterial blood gas, we will monitor once in 1 day or 2 days according to the situation needs. To either when it will be useful when we are tapering oxygen. Most of the time when SpO2 is 92, we need not do an ABG to know that oxygen is low. So usually it will be useful when we are tapering on oxygen, because beyond 99% of SpO2, PO2 can anywhere from 60 to 300. So in that situation it will be useful, and to rule out other complications like metabolic acidosis or CO2 narcosis in patients who are dependent on CO2 drive. If we put more oxygen, it can increase, and some patients may develop metabolic acidosis like diabetic ketoacidosis or lactic acidosis. In that scenario, ABG will be, arterial blood gas sampling will be useful.
Excellent, sir. So, what I understand, what is the cutoff point for patient to be shifted to ICU? How many liters? Is it the liter of oxygen or work of breathing?
Work of breathing, sir. If somebody is maintaining 99% also, if his work of breathing is very high, that means definitely they will deteriorate over few hours, because if their work of breathing is more, their demand for oxygen is also more. So they will automatically deteriorate. So work of breathing is very important point. Work of breathing will increase when we increase the FiO2. So if we are using a non-rebreathing mask, it can deliver up to 80% of FiO2. So if somebody in that mask is not okay, if work of breathing is more and its saturation is not maintaining in that, then definitely should be shifted to ICU. Because only in ICU we can give non-invasive ventilation, or FiO2 more than 80 can be delivered only in ICU.
Super, sir. Got your point, sir. If you have any questions, please drop those questions in the comment section, and I'll contact Aribai and I'll get back to you with what he thinks about your questions. And if you have any difference of opinion, please drop them in the comment section. Please leave your comments and thoughts in the comment section. And if you like the video, click the like button and subscribe to my channel. Don't forget to ring the bell just to be notified of the next video in time. Meanwhile, thanks for watching. Keep watching this space for more info on COVID. Thank you.